Hello there, and good morning to what is a really sunny day here in Stoke-on-Trent, where I'm speaking to you guys from. Um, Thank you for joining us today, and what's actually been the end of a pretty busy National Safeguarding Week for the NHS. I hope you've all managed to access the local events, and also to remind you that the week isn't over yet. We still have, at a national level, the LPS and MCA Learn Together lunch today, so still time to cram a little more into your revalidation folders. My name's Art Calder. I'm Head of Clinical Services for CHS Healthcare. We've worked with the NHS since 1995 and provide clinical services across 80% of both England and Wales, to include hospital discharge management and our database systems for complex care. We've got around 250 people today on the webinar from across the country, which is great. These are a series of winter webinars that we run each year for anyone wishing to be interested in the topics that we cover. So please do let us know if you'd like to be invited to future events. Before we go into housekeeping, let me just pass you over to the people who are really important today, and beginning with our panelist Kenny Gibson. So Kenny.
Good morning, everyone. My name is Kenny Gibson. I'm the National Head of Safeguarding for the NHS, and what we do is in the published Q&A section. Thank you for the invite today.
Thanks, Kenny. And Jonathan.
Thank you, Art, and thank you so much for the invitation. Wonderful to meet with everyone. I'm Jonathan Senker. I'm the Chief Executive of VoiceAbility. We work to make sure that everyone has a voice when it matters most in their lives. We're a leading national provider of independent advocacy support and support people to come together to have a strong collective voice as well as an individual one.
Thanks, Jonathan. And we're going to be together for almost an hour today. Just for the audience's benefit, can I remind you that there is a Q&A tab at the top of your screen. You are muted because there are a huge number of people on this event. But if you would like to ask a question, we have a back office staff group who will be looking at your questions. You can post a question on Q&A and we can look at discussing those questions in the plenary session at the end of today's webinar. Okay, so this webinar is close to my heart as a nurse, past commissioner and safeguarding lead across both children and adult services. And I guess with recent headlines such as mental health in crisis, years of scandal and false promises as patients suffer, there's never been a greater focus on the work that we do and the efforts we go to keep people safe. As a mental health nurse by profession, I was very heartened by Claire Murdoch's recent call to action to mental health trusts and ICBs in her ask that we all consider her phrase, "It could happen here." And today's webinar isn't designed to provide all the answers, but I hope it'll help us to consider what it is that we do on a day-to-day basis to keep our patients safe. And to that end, we're going to be addressing some of the discussion points around the role of continuing healthcare in safeguarding of vulnerable adults, the importance of significant others and engagement with the team around the patient, balancing care with costs, and understanding our statutory duties from the Care Act through to Mental Capacity Act, including our national guidance, predominantly paragraph 190 of the national framework. We're going to talk a little bit about how safeguarding issues can actually be prevented. And then finally, in a time of austerity, how a focus on patient safety can actually act as an economic approach to delivering NHS continuing healthcare. So if I might turn to Jonathan then for our first question, Jonathan, from your experience and as a patient advocate, how would you envisage the current system might improve the way in which continuing healthcare plays a part in the safeguarding of vulnerable adults?
Thank you, Art. That's quite a big and hugely important opening question. So thank you for that. I think the first thing to say, obviously, is we know and we acknowledge that everyone is working extremely hard and with every intention to do the right thing. I think there's many ways that the system can improve. I'd like to focus mainly on one of those, which is around how it is that we hear the voices of people, how we hear the voices of people that draw on services, patients and families. Because if we think about it, really every instance where there is abuse is an instance where a voice hasn't been heard, whether that's poor Awab Ishak, or whether that's the dreadful events at Winterbourne View, at Walton Hall, at Edensfield. We know the litany of dreadful things that have happened. Every one of those is a time when people's voices weren't heard, weren't responded to. Or if we flip it the other way around, every opportunity, every engagement is an opportunity to see and to hear people's voices and to act on those. And I think we've got a really important missing ingredient here, and I want to focus on that. And that is that within CHC processes, it's really unusual that people have independent advocacy. It's really unusual that people have independent advocacy through CHC processes. It does happen, but not nearly as often as it should do. And we know from our experience just how valuable that can be. So one of the things that we think is really important is that there's a clear, unambiguous legal right to advocacy in relation to CHC. We don't think we should wait till there's a change in the law, because ICBs and local authorities do have a commissioning role, and they do have the authority, and they do have guidance that encourages them to make sure that people have that independent advocacy. So there is somebody involved in those processes that's independent, that can hear that person's voice, that can make sure that it's responded to. So that's one of the key features that I'd really like us to focus on in this conversation. And I'm sure we'll discuss that a little bit more. I think we have to acknowledge that this is within a system that's working under a huge amount of pressure, and it's been commented on by the Ombudsman, and it's something that we see through our advocates as well, who are reporting to me that there's almost a culture, and it's been described by others, a culture of ineligibility, a perception that continuing healthcare is something that's almost unobtainable. And I think that that's something that we need to challenge. We need to make sure that people have that independent voice in the system to challenge it. Moving on to a bit of
Jonathan.
Thank you.
I think those messages are heard loud and clear. And just following on from that, if I could invite Kenny to perhaps tell us from a policy perspective, in what way can continuing healthcare then contribute to the messages that Jonathan's giving us and ongoing safety of others?
So thank you for the question, and well said, Jonathan. I couldn't agree more in terms of the independent advocacy, and thank you for recognising that the last 3 years has been extraordinarily challenging. However, from a policy and a system leadership point of view, COVID has also demonstrated to us that mental capacity, whether it's deprivation of liberty safeguards or mental capacity itself, it's actually more than a contractual obligation. These people, these citizens, their most vulnerable time, they're more than a tariff. And so mental capacity needs to be an organisational cultural matter. And if I'm honest with you, I don't think we fully understand yet how mental capacity policy and deprivation of liberty safeguards policy will have an impact from COVID. We don't understand the full impact of trauma and trials and lockdown of COVID. And so therefore, we need to do some more listening. Yes, we must listen to the citizens who are impacted by mental capacity and deprivation of liberty safeguard. That's a given through independent advocacy. However, We must also listen to the practitioners, the assessors, continuing healthcare staff, in order to understand that things like community dolls can have a positive impact. I think the whole system is born out of reflecting on incidents, which we must, and thank you for calling out some of the horrors and the tragedies, Jonathan. But I think we've also got to be in an organisational culture across healthcare, social care, and particularly in the NHS, where we've got to muster all of our safeguarding mojo that we can. We've got to demonstrate compassionate leadership. We've got to begin being trauma informed. We've got to begin using emotional intelligence as well as data intelligence. And we've got to begin demonstrating empathy and strength-based in the families that we're working in, the communities we're assessing with, and the services that we're covering. So I think the policies and the impact on policies, we've got a deal of work to do. Yes, we will reflect on incidents, but I'd like to think events like this, as a system leadership event, must also learn from excellence, because there's far more excellence than there is incidents and awful moments.
Thanks, Kenny. Loud and clear. I think what we're hearing there was around the number of patients that we work with in continuing healthcare who perhaps don't have a voice, or certainly do not have the mental capacity to self-determine their life's intentions and aspirations. Building on from that, in continuing healthcare, as you quite rightly say, and thank you for mentioning it, Kenny, and Jonathan, we are under incredible pressure and incredible scrutiny. We have a series of metrics that are performance-based, time-based around assessment. But in terms of our existing cohort of patients that we care for, not just in continuing healthcare, but all those people that we look after in care homes with nursing under the funded nursing care system, I just wonder, Jonathan, if there's more that we could be doing in our review process to keep people safe.
Yeah, I think that's a really good question. I think sort of following up on Kenny's theme about really embedding a culture around an understanding of the Mental Capacity Act. You know, the Mental Capacity Act forces us to think about what really would, you know, what does the world look like for this person? What's their past and present experience? What's their beliefs? What are the things that shape them? And I think that really having people that can walk a mile in somebody's shoes, and that's, again, you know, I will stress the importance of independent advocacy in that. And, you know, I think of a woman, Joyce, who I met, who it was really clear that her world was very closed in. Her only real contact were the stories that she imagines in her mind from the people that she could see out her window. There were few people walking into her room on a ward in a nursing home, and it was because her independent advocate was able to pick up on that and feed that into the review process that people understood that life needed to be bigger than that. And that, yeah, kind of her situation probably bordered on neglect. She had very little contact with any other human being, and it was only through seeing that and responding to that. So I think, yes, we absolutely, and I totally agree with Kenny, we need to celebrate the good stuff and the great stuff. We also need to make sure that people have a strong voice so that they are heard, and we can keep people safe by helping people to lead a better life. And I think that does take, in a system under pressure, that does take that independence, sometimes that grit in the oyster that creates a pearl.
Loving the analogy there, Jonathan. And well said again around how we can share best practice. It's certainly in my own safeguarding role, I've always said that for every finger we point, there are 3 more pointing back at us. And on that basis, Kenny, do you have anything to add to Jonathan's strong point about the more rounded role that we play in continuing healthcare, not simply about documentation, but around our wider social commitment to our patients, not just a duty, but a genuine value to embed into the workforce?
Yes, I think we need to bear witness to whether it's the 500 plus people that are coming on these conferences, etc., during Safeguarding Adult Weeks, or whether it's coming together into our supervision sessions, that a review is not simply a task. It might appear as a code on a contractual obligation, matrix, etc. It might be a KPI. However, to the person undertaking it, the clinician, the assessor, it will be part of a journey. And for the person who is having it undertaken with, the family, the person, indeed the community, in some cases the neighbours, it must be a journey that at the core of it, Art, is about the human rights of that person. And we've got to go through that journey, not as a unique assessment, but what about bringing in other contacts that the person might have as part of their legacy? Very few people are found with neurologically diverse conditions in a state of distress as an immediate emergency. The pharmacist will have seen that journey into cognitive challenge. Perhaps a district nurse might have noted some deterioration in cognitive functioning, etc. And so I would want us all to begin looking at a review, not only as a journey, but making every contact count, with all long-term condition assessments, with any visit to the pharmacy, long before this person, this citizen, becomes a patient on the continuing healthcare journey, on continuing healthcare caseload. Only then can we, as a team that wrap ourselves round citizens for continuing healthcare reviews, only then can we truly represent the voice of the lived experience and avoid the legal clinical jargon that just gets up people's backs, if I'm honest with you. So I'll be looking at the role of the reviewer to highlight, yes, care needs, absolutely, but also unmet needs. The psychosocial, the sexual, the financial, whatever we want to call it in our holistic framework. It's about meeting those needs, because this person, I now, by listening to them and believing them and building feedback from the rest of the community team, the primary care team, the acute team, I now understand and bear witness to the citizen's journey that has brought them to a continuing healthcare review. So let's be holistic, and let's have a commitment from anyone, be it a registrant, be it a professional, or be a carer, that understanding the citizen and the family, it's imperative. So I would want that. The second thing that does for me as a National Head of Safeguarding is, as we understand the person's journey into the requirement for a continuing healthcare review, there are moments, Art, that we need to challenge our unconscious bias. We need to understand our unconscious bias about how dementia materialises in the family, how domestic abuse might have an impact on someone's quality of life as well. So some of those harder moments in families and households, we might need to support colleagues, challenge others' unconscious bias towards that.
Thanks, Kenny. And I guess what I'm hearing there is that we walk into reviews with our eyes wide open and wider than the tram lines of documents set before us, wider in terms of the person as a citizen, as a human being, and as part of a wider social network. And whilst legislation may cause some consternation for people, we also have to be very mindful of our duties to ourselves through our codes of conduct, as well as to the duties of primary legislation. But they are almost secondary to our internal values. So perhaps what you're really saying is that before we look at others, we have to look at ourselves. And that's really well said. That all said, there has been some new nice guidance on safeguarding, and I wonder if I could ask Jonathan to talk to us a little bit about that and how we might look to use such guidance in the prevention of safeguarding incidents, to make sure that people are safe all the time and that best practice far outweighs incidents. Jonathan.
Thanks, Art. Oh, excuse me. Yeah, I must say also, I absolutely strongly agree with, reviews and opportunity to really look at the person, the whole person, rather than simply look at binary decision making. So I thought that was extremely well made. In terms of the NICE guidance, we've recently had the NICE guidance on providing advocacy to adults who use health and social care needs, and that says something really, really important right at the beginning of it. Immediately after reciting the legal entitlement, it says something really, really interesting. And what it does is it strongly encourages the offer of advocacy to people who need support to have their voices heard about stuff that's important in their lives that goes beyond the legal requirements. And I cannot think of people who to whom that applies more than it does to people in CHC reviews. And I think that's incredibly important. I think it's incredibly helpful in providing that urging and support that accompanies the sentiments in the national framework to make sure that people do genuinely have somebody on their side, somebody who, as Kenny is describing, can understand the whole person and bring that whole person to life in the discussions that help that person to be at the centre of their views. We've got a rather strange legal setup where there's all kinds of processes in which people have an entitlement to advocacy, but CHC decision making and reviews isn't one of them. Unless there's a local authority nexus, people do not get that independent support and voice in those processes. And I'd love to stand here and tell you about the thousands of people that receive advocacy support in relation to CHC assessments and reviews, but I can't, for two reasons. One, we suspect that the numbers are really far lower than they should be, and two, there's no data collection to actually tell us that that's happening. So I think there's some real opportunity here for all of us to make sure that people do have an independent advocate involved in those processes. There's a real opportunity to make sure that where there are existing legal entitlements, and there are existing legal entitlements in relation to safeguarding, when we're concerned that the person may be harmed or at risk of harm, to refer to an advocate. There are legal safeguards to make sure that people are referred to an advocate when they are under a deprivation of liberty, or they're being considered for deprivation of liberty, or under the Care Act. We need everyone in this webinar to be fully acquainted with and using those entitlements, but we also, I think, need to work with our commissioning colleagues to make sure that everyone that is otherwise going to be without independent support to have their voice heard through CHC reviews, through CHC decisions, has that support, both to make sure that their rights are respected, and yes, Kenny, to make sure that people's statutory rights are respected, but also to make sure the person has a strong voice, to make sure that risks around safeguarding are identified, and to make sure that we think about that whole person through the process, through the decision making, and through the ongoing support to help that person to lead their best life.
Brilliant, thank you, Jonathan. And those NICE guidance are available on the great worldwide web. We also have an internal audit system known as CHAT in Continue Healthcare, run by Quick Solutions, and that's a national contract to consider the work that we do internally, and we wait to hear whether or not those guidelines in safeguarding may be considered going forward by our colleagues at NHS England. Kenny, do you have anything else to add to that?
Just a few things about the narrative around this, because it must be a shared narrative and we need to understand our narrative. And many of the programmes of safeguarding have a very legal word, or indeed a custodial home office word. Let me give you one example that some continuing healthcare citizens might come across, and that's cuckooing. Who'd have thought 5 years ago we'd be in an adult safeguarding meeting talking about cuckooing? But that's a word created by not the lived experience. And when you listen to the lived experience of someone who has had a home invasion, it feels as if their home has been invaded. And so what I'm on a journey with is truly listening to and bearing witness to what the victims and survivors of safeguarding moments call it. And I'm apt to use that language instead of the legal language. So cuckooing I always refer to as home invasion now. And for county lines, the drug and nefarious activity lines, I call it child abuse by drug dealers. I call it out for what it is. We have got to be authentic in what the impact is on citizens of safeguarding moments. Not the legal words, and certainly not the policing words, and not the Home Office guidance words. So let's change our narrative. Let's bear witness to what the victims and survivors talk to us about in terms of safeguarding. I think also that we have got to be, this is our moment that we also need to be courageous. Because if we are truly going to stop victims of safeguarding moments or survivors of horridness, we have got to have a conversation about understanding the mindsets and motivations of perpetrators. Only by preventing perpetrators can we truly stand proud that we're not only wrapping ourselves around victims and survivors, but we're stopping the abuse, we're stopping the exploitation, and we're stopping the violence. And some of our CHC clients and the people that we assess, or the people they're living with, they will be perpetrators. Perpetrators don't just come in and out of people's life ad hoc. So I want us to be bold and brave and reconstruct the legal jargon into the lived experience. But I also think it's our moment in adult safeguarding to be courageous enough to talk about the fact that we are also here to prevent perpetrators and offenders.
Kenny, your use of the term cuckooing is actually quite timely for us in continuing healthcare, where the individualisation agenda is a wonderful way of keeping people at home, keeping people in their preferred place of care, and keeping them loved and cared for by those closest to them. But there is always a risk. So as our numbers in personal health budgets increase, as our numbers of people cared for within their own environment or supported living environments increase, in the pursuit of human aspiration, there comes with it some sort of risk. And I just wonder if you have any advice around how our review system might evolve to ensure that those risks are accommodated and mitigated.
Yes, I think any review system, if you're going to avoid a home invasion by gang masters or exploiters, if you're going to avoid scams and the shame that some people feel about unpicking scams, you've got to involve the neighbours. You've got to involve any contact that citizen who is being reviewed or assessed for CHC goes to. So what about the food banks? What about the pharmacist? What about the contacts that they might have with their peer advocacy services? What about their friends? What about their neighbours? You need a totality of people wrapping themselves around them, because CHC, like the NHS, we cannot be in every living room for 24 hours a day, and we must never be in bedrooms all the time. So we've got to know the contacts and connections and social networks and support networks that person has, and make contact with them to say, are you seeing any signs of home invasion?
I totally agree with everything that you're saying, Kenny. I think the other thing that we need to think about in this is we also need to challenge some of our standard assumptions about what's safe and what's not safe. And I think your use of the term courageous is absolutely spot on. And some of the things, and I think COVID again has sort of encouraged our thinking in that way. So the things that we considered safe, care homes, nursing homes, actually, we've found in many cases are not the safe places to be, and not the places that help people to live their full lives. Not taking away for a second the fabulous work that's done and the fabulous support that's provided in many places, but I think we do need to challenge those, and we do need to be able to exercise our professional curiosity when we're looking at things, and we need to have that very strong cultural antennae. What is the culture of this place? What's the leadership of this place? If I were somebody working in this place, would I be encouraged to speak out about stuff that
Yes.
I'm not comfortable about? So we absolutely need to be alert to the risks to safeguarding in every setting. We need to do so in a way that doesn't drive us to distraction and endless questioning, but to exercise strenuous professional curiosity, to build our muscles in terms of professional curiosity, and to share with colleagues, with supervisors, with managers our concerns, and to be prepared to speak out, and to be prepared to be wrong 9 times rather than being right and staying silent once. I think the way that we work within our organisations to engender that kind of culture and that kind of leadership is so important these days.
I couldn't agree more, and I wish to supplement professional curiosity with neighbourly nosiness. Not neighbourly nosiness that is invasive, but neighbourly nosiness that is compassion. We know the people that don't appear for the prescriptions. Why are they not being neighbourly nosy if they don't go and pick up their prescriptions every 28 days? We know the pattern of shopping and food bank attendances that our most vulnerable adults have. Why are they not neighbourhood nosiness? So I'm a great believer in professional curiosity. However, professionals are not there 24/7, 365. Neighbourly nosiness. We should all be actively wrapping ourselves round our most vulnerable neighbours as well. But thank you for recognising it.
And I think what I hear from both of you, unless you're going to tell me that I'm wrong, is I hear the words professional curiosity, neighbourly nosiness, and the potentially need to remind ourselves that we're nurses in the first instance. So when we're writing about individuals at the point of a review, and we're considering things like the STOMP agenda, is this person in receipt of an overly reasonable amount of as required sedatives like lorazepam? The question we should be asking ourselves and asking of our colleagues in care is why. And I think that's what I'm hearing is there is a need for us to be nurses in the first instance, as well as commissioners of healthcare, but also to be proactive in the work that we do in continuing healthcare, making those contacts with the team around the patient, including the professional and non-professional contributors to care, making sure we know them, making sure that we support them in order that safeguarding issues are prevented, not simply responded to. Any comments, Kenny, Jonathan?
I think that's absolutely right, and I think it's also not seeing safety in isolation. It was Judge Mumby who came out with the now rather famous phrase, which I'll probably mangle, which was what's the point in keeping somebody safe if the only consequence is making them miserable? So actually helping people to live their full and their best life. This isn't about safety alone, but it should be about the person themselves choosing the risks that they take rather than having risks imposed on them as a condition of receiving support. And I think those two things are very distinct, and it's really important that we maintain that distinction. So if I choose to expose myself to some additional risk in order to live my best life, that's completely different from being placed somewhere, having decisions taken away from me, because that's the only way that I can get support, and that exposing me to risk. I think we need to keep those two things very, very separate and focus, as Ken is urging us to do, on people's whole lives.
Thank you. In our preamble this morning, you mentioned you were asking questions around what systematic systems do we have in place for managing commissioning with providers, and I think you touched on some of the documents around contractual agreements. I don't know, Kenny, if that's anything you would want to talk about, and you mentioned peer reviews, I believe.
Yes, I think we cannot get away from the fact that CHC is a commissioned function, a very important one, an increasingly important one. If you look at the demographic of individuals, certainly the numbers are rising that are requiring NHS continuing healthcare, and the assurance of that requires compassionate leadership. Because if all the commissioners are doing, or all the compliance specialists are doing, or all that the regulators are doing is counting numbers, they will not find out excellence, and they will not see incidents per se until they happen. And the world of provider assurance visits is an interesting one, because for me, it needs to build into the new models of provider setup. So as we know, across healthcare, providers are being brought together under the NHS Act as provider collaboratives. There's no longer competitive advantage to be played out between NHS trusts and community trusts, etc., etc. And our partners in primary care, be it dentistry, optometry, pharmacy, or indeed general practice or urgent care, they are now part of the primary care networks. And I see that as a possibility of the provider of NHS continuing healthcare working through the provider collaboratives to make sure that individuals with a care plan for CHC does have access to the required NHS and the required primary care in a timely and safe fashion. So I think it would be beholden on any provider collaborative to recognise that continuing healthcare patients are a priority, and in order for them to begin being part of the assurance visits. And you know, we can do that together. That there is absolutely a space in CHC for having peer review assurance visits with their foundation trust, with their primary care network. And so that way we can mutually learn to the patient's advantage or the CHC citizens' advantage how we need to work a strength-based approach and make that person's individualised care plan in CHC work for them and their family. So I think whether it's assurance visits or indeed quality improvement programs, we've got to bring CHC assessors and commissioners to the table of provider collaboratives and integrated care partnerships, because that is where it works. The final thing I'd say about assurance is that why is there not a move in continuing healthcare to have, as we are, nursing students, to have shadows and student placements as part of pre and post registration training? Let's make every CHC service a student placement for occupational therapy, for GPs, for medics, for nurses, for anyone with a queue into community and quality improvement, community services, community care, social care, so social work student placements as well. So I think I'd be urging us all, as when we think about the aspects of assurance and reviews for assurance, let's be creative enough to go for peer reviews with our provider collaboratives and primary care networks, but let's really seize the moment and get students and shadows and peer reviewing into continuing healthcare.
Kenny, thank you. I could kiss you for that one. That's the so for those that don't know, I was a teacher before I was a nurse, and I always talk about continuing healthcare education, not continuing healthcare training. And pre-registration training is something that is very close to my heart, and I think we're one of the first organisations to agree a full 8-week placement for third-year students from Oxford Brookes University in continuing healthcare. Those students are placed across an ICB in the southwest. So if people do want to know more about that programme, I'm very happy to talk that through. But it's really well said, because recruitment in continuing healthcare is a real struggle for us. The skill set required is quite a high level of skill, and it is a tension-laden value system of healthcare that does require a specific set of skills. So anything that we could do and perhaps talk about later, potentially as a webinar around workforce education, then please do let us know. Jonathan, do you have anything else to add to Kenny's comments?
I thought Kenny captured things brilliantly well.
Okay, thank you. Kenny mentioned increasing numbers of people being found eligible to continue healthcare, and that is true. From our colleagues in the Strategic Improvement Programme and their research in CHC trends and patterns and population demands, I think we estimated a 5% increase in both caseloads and costs. Year in year, but at times of austerity, those costs currently are ramping up quite significantly. And so I guess my next question, possibly to Kenny, if I may, is how could a more intense focus on keeping people safe actually provide an economic contribution to continuing healthcare processes?
A really timely and interesting question, that the system leadership question, isn't it? We cannot help but understand the political imperative to do this. Not only the direct here and now monetary saving, but actually the saving on trauma, the saving on grief, etc. So we are at this moment nationally where safeguarding, along with patient safety, along with risk and quality improvements, are now being tethered to the National Quality Board. And that's a really important moment for us in healthcare, because it means it's been externally scrutinised by Local Government Association, the Association of Directors of Adult Social Services and Children's Social Care, along with august other professional bodies. So patient safety, risk, quality improvement and safeguarding, they're now all tethered into that national scrutiny. I think we do need to bear witness that whilst we can be leaner in our review assessments, we can optimise value for money as commissioners, and we can certainly look at the financial burden of negligence, for instance, and the cost of undertaking investigations and inquiries galore, most of which, I have to be honest with you, appear to have a copy-paste recommendations, regardless of the year. The venue might be different, but we are in this perpetual cycle of the same recommendations, which is quite distressing as a clinician. And I can only imagine the emotional cost that has, because for the historic victims and their families, and now the new victims and their families. That cost is unfathomable. The re-traumatizing of investigations and publication of reports that most families who have been bereaved through a lack of quality or mistakes or errors across the health and care system, or negligence across the health and care system, I cannot even begin imagining what that does to the re-triggering of trauma. I think it is about time that, whether it is independent inquiries, but also things that impact continuing healthcare that we might not think about. For instance, domestic homicide reviews. For instance, child death overview processes where an adult with CHC is in the family. Mental health homicide reviews, perhaps per se, I don't know. The plethora of independent inquiry, usually about a death. I think we now need to have some sort of rethink about how do we take those. I mean, for instance, in my job, I have the humbling job of reading at least 15 domestic homicide reviews every month. Yes, folks, 15 of them every month. They have increased slightly. The child death overview reports, a growing number every month. And to a report, there is always maybe a vulnerable, complex adult in that family who has been impacted, and an increasing number of those might be CHC clients. So whether it's a CHC reviews, whether it's assurance reports, or whether it's a plethora of death reviews and independent inquiries, we need the policy drivers, the departments of health, to hold us to account now about why these omissions are perpetuated, why the regulator keeps on missing things on their visits. So the whole system needs to look at this in its totality and get things right first time, grift as we call it. Not because there's law, not because there's regulation, but because protecting from safeguarding moments, protecting someone's human rights, protecting from harm, protecting from violence, it's the right thing to do. So maybe it's about time that 2023 was a call to action year.
Totally agree. We don't need less inquirers. We need less reason to have inquiries by actually implementing the changes that we've known for years and years and years need to be made. Another absolute case in point, really driving forward changes so that people with learning disabilities and autistic people are no longer detained in hospital. We know how to do this. We've known how to do it for ages. We've written reports. I've been responsible for chairing and writing reports, and we've all done it. We know the changes that are needed. We need the leadership, drive and political will, as well as in some cases the investment to get on and do it. I think in a more day-to-day way, the other way of absolutely driving value for money is listen to people. Listen to people. May not always save money, but it will make sure that the money that's spent is money that's spent on what it is that people really want and need. That's the way that we drive real value for money.
Yeah, Jonathan, I couldn't agree more, but I'd be more courageous and bolder. We must not only listen to the lived experience, we must demonstrate we've borne witness to it, and we've done shoulder to shoulder with that lived experience. But also, colleagues on this call, remember your voice is just as important. Let's make Adult Safeguarding Week the moment when we stop reading reviews, we stop recommendations, reflecting on our navel about recommendations from these reviews. I would want every clinician and practitioner and CHC colleague on this call to stop calling their feedback from a family home or a family. Stop calling it anecdote and call it what it is. It's local practitioner intelligence. It is just as important as your KPI data. So when you bear witness to something you're told by a family or a citizen, let's call it and value it and bear witness to it by calling it local practitioner intelligence. Pass it to the SAB chairs, pass it to the designate adult professionals, pass it with a Section 42 referral. And if your Section 42 referral does not bear fruit, escalate it, chase it. Our bearing witness to the trials and tribulations in people's homes and CHC citizens is just as valid as a social worker's threshold for adult safeguarding referrals. So we've got to begin using what we hear, what we see, what we understand as local practitioner intelligence. Never let anyone tell you it's anecdote.
Well, gentlemen, for once, I'm stuck for words. I couldn't say any better. What you guys are very clearly saying is let's take that audit cycle into its kinetic form. Let's turn that latent energy in investigations into actions following those investigations. But equally so, let's look at ourselves as practitioners and the work that we do on a day-to-day basis to ensure that those issues for escalation aren't necessary, because we do keep everybody safe. That would be the ultimate utopia in the world going forward. So, ladies and gentlemen, that sort of brings us to the end of our questions. And throughout the session, the backroom team have been looking at questions that you have been sending in. Now, neither Kenny or Jonathan have seen these questions, so it is a little bit on the hoof, and we won't hold you to this, but we do have a couple of very specific questions that I've been asked to raise with you, and I'm not sure you're going to give us absolute concrete answers, but you may want to signpost individuals. I have one comment here around the suggestion that during COVID and lockdown, a number of continuing healthcare assessments and reviews became virtual. I think the person means remote, not virtual as in almost a review, because I'm sure they were full and robust assessments and reviews, but a remote process using Teams predominantly as an opportunity to assess and review individuals. This replaced face-to-face visits, and the question is, I would like to ask your thoughts on this, and whether now should be a message from, or we should be receiving a message from NHS England that all CHC assessments and reviews should be reverted to a face-to-face basis as we did pre-COVID. So that one, I don't know if Kenny, you'd like to pick up on that from
yes.
an NHS England perspective.
From an NHS England but not CHC basis, NHS safeguarding basis, I think it is time now to review the digital enabled or remote access assessment. I think there is no substitute for having live ears, live eyes, and just intuition as you walk into someone's home, as you sit down and absorb. I think there's no substitute for that. However, I'm also an advocate, particularly for the review, that it might be we know them well enough, or the community team that wrap themselves around them knows them well enough, that if it is their choice to be digital enabled or remote, then we should also offer choice. But yes, it is time to review the initial assessment, I would propose, but I am not the head of NHS continuing healthcare.
I broadly agree. I know that our advocates find it so important to be with people in person, to be able to see around the corner, to be able to hear, to smell, to notice what's really going on around there. And I think it's absolutely the same for people who are undertaking CHC reviews. There may be occasions where the person themselves is really clear that they're preferred, and and they'll be happy for something to take place online. But I think we absolutely need to take every opportunity, as I said at the beginning, so every opportunity is an opportunity to hear people's voices. Every opportunity is also an opportunity to identify if there's harm that or concerns, or just that stuff that makes us feel a little bit uncomfortable that we need to think about and need to think whether it adds up to something else. So I think the default position has to be really clearly that things are face-to-face, in person. There may be exceptions, and those exceptions should be driven by the individual themselves, their preferences and their needs.
And I think that I think the Law Commission has actually published material on the approach to remote reviews and assessments in the Mental Capacity Act and updated that information recently. But I guess the message that we're hearing to the delegates today is that that might be a conversation that needs to be driven through the regional forums and escalated to the heads of assurance across NHS England and DHSC.
Yeah, don't send it to the heads of safeguarding.
Okay, just time for one more point, I guess, which is some people have been asking for access to the documents and advice that both Kenny and Jonathan have alluded to in the seminar, and we have everybody's email address and contact, and we can certainly send those connections and links out to you all, and I'm sure that both Kenny and Jonathan would be available to talk more about their services, certainly VoiceAbility as a national voice of the patient, and of course Kenny and his team's work in their local NHS agenda, but also the integration agenda with our colleagues in social care. I know we have a number of social care colleagues with us today.
Yes, and we'd be particularly keen to hear from people who may want to work in collaboration to make sure that we can make sure that people have a stronger voice in their own lives and in their localities and in shaping services. So very, very happy to be contacted and for my details to be forwarded to delegates today. And
Jonathan and Kenny, I have to say I'm just being fed. There are a number of comments coming through to say, and I will quote one for you, on how refreshing this session has been for a change where safeguarding is front and centre of all that we do and is seen as a main priority by our health services in continuing healthcare. I hope we all will take away that message and consider how we can embed safeguarding into everything that we do every day that we do it, reminding ourselves that we're practitioners first and human beings first before we review our systematic approaches. I think Kenny mentioned doing the right thing is so much important, equally important, sorry, as doing things right. The suggestion here, I have a comment coming in saying, thank you, I know working in some areas where this has been ignored, and that's difficult to hear as an almost lifelong practitioner in complex care and safeguarding, but we hear it now. So on the basis that we have no more questions, can I thank Kenny and Jonathan so much for supporting continuing healthcare in the work that we do, providing advice and lots of stimulating commentary that we need to take back and consider for ourselves, and consider sharing with each other, sharing with our colleagues in social care. I think we heard from both Jonathan and Kenny about the opportunities we have together in terms of integrating not just our services but our values. On that basis, thank you once again. Do tune in later for the NHS England webinar in LPS and Dolls, and happy National Safeguarding Week. Have a great weekend, everybody, and we'll see you next month. Bye bye.
Thank you. Bye bye. Lovely talking with you.